Hi, how are you doing? My name is John Oxentenko. I'm going to be your nurse today. So the first thing I've done here is I've assessed the situation. It seems to be safe. The patient, when they walked in, their gait was normal. No signs of obvious deformities. I'm looking here, the posture is erect. The patient does not seem to be in pain at the time. They have a relaxed, pleasant affect and mood. Again, no obvious deformities. The head looks to be normocephalic, atraumatic. We'll assess that further later. The patient is well groomed, fairly symmetrical in the structure, athletic build, well nourished. So now we'll go straight into the head assessment. So I'm going to palpate your head now. Okay, I'm looking for masses, lumps, tenderness. If anything hurts, let me know. Okay. The hair is clean. Again, the head is well groomed, no signs of infestation. Patient is tolerating procedure well. Okay, I'm going to come down here. I'm going to palpate your temporal arteries. I'm sorry about my cold hands. Okay, +2 bilaterally. Now I'm going to palpate your joint here, your temporal mandibular joint. If you could open your mouth for me. Close it. Open it again. Okay, no clicking on either side. Okay, so the next thing we're going to do is we're going to palpate the face for any tenderness. Does that hurt at all? No? Okay. I'm going to palpate the ears. Does that hurt? If anything's tender. Okay. Now the skin color is tones of pink and peach and moderately tan. Looks healthy, no obvious lesions, very little to no acne. Skin seems to be well nourished, well hydrated, warm, bilaterally. As we move on, we're going to assess the, okay. Next thing we'll do is I'm going to palpate your lymph nodes here. So we're going to go to the submental, submandibular, jugular digastric. Okay, I don't feel anything there. Now we're going to go to the preauricular, posterior auricular. Okay. Superior cervical or superficial cervical. Now we're going to deep cervical chain. Tenderness, okay, and the supraclavicular. Could you bring your shoulders in a little for me? Just relaxed. That's good. Okay. Oh, and the occipitals back here. They are non-palpable, non-tender. Okay. Next thing we're going to do is assess the facial structures. So, before we assess the facial structures, when the patient came in, their hearing seemed to be intact because they were responding to me when I asked them a question. Their eyesight seems to be fair because they were able to maneuver their way into the room. And we'll assess all this further. So, the next thing we're going to do is we're going to look at your eyes. This light's going to be kind of bright. Look at my finger for me. Okay. Okay. Now, look at my finger. All it in. Okay. So we've assessed that the pupils are equal, round, reactive to light and accommodation. Next thing we'll do is we'll do extraocular eye movements. So follow my finger. Minor bit of nystagmus in the right eye in the superior medial position. So we've assessed cranial nerves 3, 4, and 6, which that's nothing to be concerned about, don't worry. We've assessed cranial nerves 3, 4, and 6 with that. Now I'm looking at the eyes. The sclera is white. The conjunctiva, let me just look at your eye real quick here. Okay, the conjunctiva is pink, moist, no signs of inflammation, infection, trauma. The whole general head structure is normocephalic atraumatic, and the patient is wearing contacts at this moment. The irides are equal, and the cornea on both sides is clear. So, next thing we need to do is we're going to look for the red light reflex, and we're going to see if we can locate the structures of the eye. So if you could look up at the top of that wall over there for me, I'm gonna hold your head here. I'm just gonna shine this light in your eye real quick. Okay, we have the red light reflex. Chase it in. Don't kiss your patience. Okay, so we have the disc and we have blood vessels. And the blood vessels are traveling away from the disc. How's that feel? You okay? Okay. Now we do the same on the other side. So we've assessed the structures of the eye. We've assessed cranial nerves 3, 4, and 6. We can go ahead and deal with cranial nerve 5 here with the cotton swab. If you could close your eyes for me and tell me when you feel the cotton swab. Okay. Okay. So we've assessed the ophthalmic branch of the trigeminal nerve. We've assessed the maxillary and the mandibular of the trigeminal nerve. So that's 3, 4, 5, and 6 we've taken care of. Now the next assessment we're going to do is of the nose, and I just have to do one and say that we do both of them. So now we're going to assess the nose. Get you to lean your head back a little bit for me. Okay. So we can see the inferior and middle turbinates, both sides. Okay. So the septum is midline, no signs of damage. It seems intact. There's equal distribution of hair inside the nose. The inferior and middle turbinates are visible. If you could occlude one nostril for me. Breathe. Okay, now occlude the other one. Breathe. Okay, good. So, equal patency on both nostrils. Now we're going to go ahead and look at your ears. Let me do this side here. Now, we've already palpated the ears. There's no tenderness. The structures seem to be intact. They seem equal on both sides. So we're going to do one, and we do the same thing on the other side. So, with an adult, you want to lift it up and back. And I'm going to slide this in your ear and take a look. Okay, that looks awesome. Oh yeah, that's awesome. Okay, so the internal structures of the ear. The tympanic membrane is pearly, gray, no signs of inflammation, no signs of inflammation or injection or bulging. So there's no signs of perforation either. We can see one of the bones of the inner ear there visible through the tympanic membrane, so it's translucent as well. Now we're going to do a hearing test. If I could get you to take your finger on your right ear and just do this, what I'm going to do is I'm going to whisper in over here, and I want you to repeat the words that I whispered to you, okay? Are you ready? Table. Table. Okay, good. Car. Good. Okay. Nursing. Good. And we do the same on the opposite side. So we've assessed the hearing, we've assessed the ears, the nose, and the eyes. Have we assessed your mouth yet? No, we haven't done that. So let's go ahead and do that. We'll first assess the structures of the mouth. If you could open your mouth for me. Let me go ahead and get this. What else do I need here? Okay, good deal. Alright. If I can get you to open your mouth for me. Say ah.
Ah.
Okay. So when he says ah, we're assessing cranial nerve 9, and the soft palate rises. The uvula is not deviated, it's midline. If you could open your mouth again for me. The mucous membranes are pink and moist. If you could raise your tongue. Okay. Sublingual area is moist. No signs of inflammation. All the teeth seem to be in position. There seem to be no missing teeth. Have you had your wisdom teeth removed? Okay. There are no wisdom teeth. And let's look one more time. I'm sorry. If you could say ah for me.
Ah.
Now I'm going to just look around in here a little bit. Okay. No signs of lesions. Trauma. All mucous membranes seem to be pink and moist. Can you stick your tongue out for me? Okay. Tonsils are a +1. Very, very slight +1. Now, say ah for me. Stick your tongue all the way out. Say ah.
Ah.
Okay. Gag reflex is present.
Should have warned me.
Yeah. That's the idea. Okay, so gag reflex is present. So now let's go ahead and move on down to the neck. Well, this is way over here. Okay. For the neck, I don't need anything immediately. Actually, you know what? I do need this back. Okay. So the first thing I'm going to do is I'm going to assess for jugular pulsation. So look straight ahead for me. There's a slight jugular pulsation that's to the left of the to the outside of the carotid pulsation. Did we palpate your? I think we did, didn't we? Okay. If you don't mind, I'm going to palpate the rest of your neck here. Okay. So what we're looking at here is that the trachea is midline. No obvious lumps, lesions. Does any of that hurt? Okay. So neck seems to be fairly symmetrical. All the structures seem to be pretty even. There's the jugular vein right there. Probably see it in the video. It's a pretty good one. And you can see a slight pulsation in that one. It's a little bit better than on this side. So the next thing we're going to do is assess for movement. Can you move just follow my movements. Move your head this way for me. Okay, this way. As far as you can go. Okay. Go back. Okay, forward. Okay, now look side to side. Okay. Now what we're saying, he has a little bit of a constriction when he moves his head to the left, which is probably nothing to worry about, probably just needs a neck alignment, but that is something to take into account later when we do the spine assessment and such. Now if I could get you to take your shirt off for me, and to sit down here. Okay. We're going to go ahead and palpate the thyroid. So my hands are a little cold, I'm sorry. If you could move your head slightly to the left and down.
Can I see the video? Or is it fine? Let's see.
Okay. Very strong carotid pulses. And the thyroid is slightly palpable. Just barely, I think that's the thyroid there. Okay, so we've assessed that. The next thing, if I can get you to shrug your shoulders for me. Okay? Now push up. Okay. Turn your head, or push your head to the left. The left, sorry. Go ahead. Okay. Push your head to the right. Okay, so we've assessed the accessory muscle strength, or the accessory nerve innervation there by doing a neck strength test and a shoulder stroke test. So the next thing we're going to do is we're going to move on to the thorax. Now I can see, looking at him right now, and you may be able to see this in the video, he has severe scoliosis. It's actually very pronounced here. So this is an interesting patient to work with. No obvious lesions, deformities, or anything like that, other than there is a significant curvature in the spine. There is asymmetry in the muscle structure here. The left back muscle sticks out. The left latissimus dorsi, I guess, sticks out significantly more than on this side here. And there is a curvature. Now I'm going to palpate. Here we go. Now I'm palpating the spinal processes to look for any deformities. Now, man, that is a curvature if I've ever seen one. Look at that. That is crazy, man. His spine, actually, the reason this muscle sticks out so much is because his spine is up underneath it. That's something. So, yeah, you have severe scoliosis. Okay, it comes back midline. Okay. Does any of that hurt you?
No.
Now I'm assessing for CVA tenderness right here at the costal vertebral angle. And the patient is denying any tenderness. Okay. All the spinal processes seem to be roughly the same size, the same length, how they stick out. Okay. So we've palpated. We don't see any obvious lesions or anything like that. We don't feel any lumps, bumps, or any. The patient denies any tenderness. So we would palpate all the way down on both sides. Okay. All right. So the next thing we're going to do is we're going to assess his lungs. So the first thing we do is we'll go ahead and percuss, and then afterwards we'll check for diaphragmatic excursion. So I'm going to go ahead and percuss on you here. We're going for the intercostal spaces. Okay, you hear that? Yeah. So so his lungs are somewhere right around there. So, take my pen. And what I'll have you do is I'm going to have you breathe in, okay, and breathe out and hold it.
Okay, breathe in and then breathe out. And hold
Yeah,
it.
take a deep breath, breathe out, and hold it. Okay. All right, you can release your breath now. All right, take a few deep breaths for me. All right, now I want you to breathe in and hold it. Okay. So, we have roughly 7 centimeters of diaphragmatic excursion. So, you can Reduce your breath. I'm sorry. I apologize. That's my fault. Okay, let me put this away here.
That's fine.
So,
Felt good.
all right. So next thing we'll go ahead and do is see if we can get any tactile fremitus here. Can you say 99 for me?
99.
Say it real deep.
99.
Do it again.
99.
Okay. Do it on the other side. Okay. Go ahead.
99.
Okay. So of equal bilateral tactile fremitus, which is the vibration we feel when he does that. He says 99 deeply. Okay, the next thing we're going to need to do here is, if I could have you, oh, yeah, one other thing real quick. When we're looking at the structure of his thorax, we're looking for a 2-to-1 ratio between the anterior-posterior diameter and the lateral diameter. You want the lateral diameter to be at least twice as wide as the anterior-posterior diameter. And he is well within twice as wide. He's actually about 2.5 times, which is good. No barrel chested. Do you have any difficulty breathing? Okay. Why don't you go ahead and sit back down there for me then. Okay. So, we'll go ahead and listen to your lungs. So I'm going to come back here behind you.
Okay.
Now, one other thing. Let's go ahead and move this back. Okay. One other thing to remember is that we assessed one side of the lungs. You want to do the same thing on both sides. So, we'll go ahead and listen to lung sounds on the back, and then we'll move to the front. Breathe in for me. Breathe in. Breathe in. So we have some coarse crackles in the left lower lobe, which just a small amount. Have you had a cough recently?
If I cough, would probably go away.
Okay, yeah, it probably would. Give me a good deep cough. Okay. All right, now we'll listen to the top. We'll first listen right above your clavicle in the V area here. Breathe in. Okay. Okay. And again, we can hear a little bit of coarse crackles in the left lower lobe from the anterior and posterior side. So the next thing we're going to do is, if I could have you lie down for me. I'm going to go ahead and assess for, if you keep your hands at your side, we're going to go ahead and look for pulsations. Okay. Now he has a very healthy pulsation in his abdomen, and there is a precordial pulsation. The chest wall slightly sinks down with every heartbeat, and his carotids are very active. +3, +4 carotids. Okay, now I'm going to feel for what's it called? Go and feel for heave here. So I'm going to put my palms on your chest. Sorry, I know it's cold. Okay, there's a slight amount of heave where the chest wall depresses slightly with each heartbeat, which is really interesting. I've never felt that before. Um,
What does that mean?
it varies. If you have a lot of it, we're going to be a little concerned, like cardiovascular health. But when you have barely any, that's a normal amount to have.
Oh,
Slight amount of Eve.
okay.
Okay, so I'm going to listen to your heart sounds now. So the first thing we'll listen to is the aortic and the pulmonic, which are S2 sounds. We'll look for any variations. Okay, so we've listened to the S2 heart sounds, which are the aortic and pulmonic. We went down and listened to the tricuspid and the mitral. The mitral is also the PMI, the point of maximal impulse. So we're going to listen for a full minute there. We won't actually do this. We'll just play do it. But we would listen for a full minute there and listen for rate and rhythm. Okay. And the rate is somewhere around 70 something beats per minute, and the rhythm is regular. Now, the next thing to do, if you could sit up for me real quick, so I don't get out of line. I assessed your upper extremities, didn't I? No, I didn't quite do that. Anyway, let's do it again. If I didn't do it, why don't you sit on the side of the bed here for me? Okay. Could you raise your arms up for me?
Okay.
Okay. Bring them back down. Put them back behind you. Put them straight out. Okay. Now put your hands behind your head. Okay, good. Now take my fingers and squeeze as hard as you can. Okay. Equal strength bilaterally. Range of motion seems to be intact for the upper extremities. I'm going to see if I can feel your nodes here. And I do not. Touch the other side. Okay. Let's go ahead and feel your pulses. I'll just do it on one hand here, on one arm. Brachial pulse is a +3. Sheesh. Radial +2. Ulnar. +2. So, and we do that bilaterally. I'm looking at his skin right now on his anterior surface of his thorax and his arms. The color seems to be consistent. Extremities are warm bilaterally, equally. Extremities seem to be equal in size bilaterally. Range of motion strength is equal. Pulses would be equal. And with that, I guess you can lie back down for me. So we have assessed the lungs, we've assessed the heart. Now the next thing we need to do is we need to assess the abdomen. So with the abdomen, we're going to first look, we're going to listen, and then we're going to feel. So, just looking at his abdomen, I can see that it's flat. He has an athletic build, so he doesn't have a beer gut. I can see an aortic pulsation here, just looking at his stomach, and we'll assess that later. Equal hair distribution on either side. Umbilicus seems to be clean, intact. No signs of infection. Symmetrical structures of the stomach. I don't see any obvious bulging upon first inspection. So we're going to go ahead and listen to your stomach here. We're listening for 7 vascular sounds. First we'll listen for renal. iliac. Then we'll listen for aortic, renal, iliac, and then femoral. So we'll go ahead and do that using the bell. Now the patient is uncomfortable with being naked on camera, so we're not going to be taking his pants off here. We'll just be doing everything around the sweatpants. So we've assessed the vascular sounds. The next thing to do would be to assess bowel sounds, but when I was listening to vascular sounds, I heard bowel sounds. So I know there are bowel sounds in all 4 quadrants. The next thing to do is to palpate or percuss. I'm going to palpate first. So, sorry, I know my hands are cold. I apologize here.
This snow's cold.
Okay. Here we go. Actually, I'm going to go ahead and percuss first. Let's do that. So the first thing we'll do is we'll percuss the liver. We'll see where it's at, and then we'll try to palpate it and move on from there. So start up here. Okay. That's liver. So liver. Liver. Flexion muscles. Abs. Yeah. Okay. You can release them. Relax your abs. Feel this side here.
Oh, man.
Sorry. Now, the structure of the rib cage is a little asymmetric in this patient. So I thought I was past it, but I was actually on a rib there. So I'm going to continue. Okay. So we have the liver from right about here to here, which is roughly, let's see what the distance is. She's about 10 centimeters. Okay. So we're going to go ahead and try to,
Okay.
we're going to go ahead and try to palpate the liver. So if you could breathe in for me. Breathe out. Sorry. Okay.
It's hard to stay relaxed.
I can't quite feel it. Let me try one more time here. Breathe in. Okay, there we go. So we can feel the inferior border of the liver there. Sorry.
It's so
Are you
weird,
okay?
really. Yeah.
What it is that there's a vascular swoosh feeling where you actually force blood from the liver, from the hepatic portal system back up to your heart, and it makes you feel, gives you a feeling of fullness. So anyway, so we palpated the liver. It's well within the inferior-costal border, and it's well within the margin, so we're not concerned about hepatomegaly. We'll go ahead and percuss the rest of the stomach here. Okay. Oh, that's good. Okay. Have you eaten recently?
Yeah. Oh.
Yeah. I'm hearing dull noises over his colon, so we know that he has food in his digestive tract. But other than that, we hear general tympanic percussion sound across his abdomen, except his liver, which is dull. Now we're going to assess for splenomegaly here. Assess the sound of the spleen. Now I'm going to go to the last intercostal space, mid-axillary. Now could you breathe in for me? Breathe out. Okay. We have no change in the sound, so no reason to believe that there's any splenic enlargement. Okay. Let me make sure here. Let's see. So you can go ahead and sit up for me now if you want. Okay. Making sure I didn't miss anything. Okay. I'm sorry, you're gonna have to sit back down. All right. Now for the inguinal assessment, I would go ahead and palpate the inguinal nodes and do the femoral pulses. So I would, if you don't mind. Okay.
I only found it once myself.
Tell me if any of this is tender.
No, I tend to.
Okay. Okay, there's a really good femoral pulse. Okay, so his pulses, femoral pulses are +3 bilaterally. And let's go ahead and move on to your lower extremities. Would you mind if I see your legs here real quick?
Sure, go ahead.
All right.
Relax.
Yeah, just lay them down, that's fine. Okay, so we're looking at hair distribution here. The hair distribution seems to be even on both legs. I'm feeling no edema. Is any of that tender? Okay. Legs are equal in size on both sides. I'm going to go ahead and grab the popliteal pulse one here. Okay, +2. +2 bilaterally popliteal pulses. So, we'll go ahead and get the rest of the pulses and then we'll assess the rest of the feet and legs. So, posterior tibial, +2. Yeah, you have awesome pulses. Man. Yeah, posterior tibial +2 bilaterally. Dorsalis pedis. +2. +2 bilaterally. So, let's go ahead and twist this so that you can see his feet a little better. Okay. So, the next thing we're going to do is we're going to go ahead and assess for, we assess there's no edema. Would you mind if I take your sock?
Go ahead.
Get both of them off real quick. Here, I'll get the other ones. All right. So, let's go ahead and assess for capillary refill. Okay. Okay, capillary refill is less than 3 seconds. I'm feeling the extremities. They're warm, warmer than my hands, bilaterally, and equal. General structure of the foot, I'm seeing no abnormalities. They seem to be well groomed. No lesions, no swelling on the feet or the ankles. If I can get you to lift your feet up, okay, put them all the way down. Okay, side to side wiggle. There you go. Okay, so we're assessing for nerve innervation, range of motion here, and the ability of the patient to obey commands. So now, if I get you to push on my feet, okay, bilateral strength.
In your hands.
I mean, I'm in my hands. Push with your feet on my hands.
Okay.
All right. Pull. Okay. So the patient has bilateral strength in his lower extremity. So I'm going to take your toe and I'm going to put it in position. I'm either going to put it up, down, or medial, and or midline. You tell me.
Tell you where you're putting it.
Yeah. Close your eyes.
Okay.
For me.
Putting it up,
Hold on, not yet.
wiggling it. Okay, up, down, middle, up,
Okay. Let's try the other one.
up, down, middle.
Okay. Good. So, patient passed the test. That's good. That is very good. Could you sit up for me now? Well, before you sit up, I'm sorry. Before you sit up, go ahead and lift your knee up for me towards your head.
This?
Yeah, like that. Okay. Now do the other one.
At the same
Drop.
time?
No, just drop it down and do the other one. Okay. Drop it down. Now keep your legs straight and lift it up towards your. Good. All right, you can put it back down. Now do the other one. Okay. Put it back down. So we've assessed range of motion in the hips and knees, and in the ankles. So the lower extremities, we've assessed the range of motion, and we'll assess the strength of everything but the ankles in a second. So if you go ahead and sit back up for me.
Okay.
This thing pointing the right direction here. Okay. So, I'm going to use this paper clip to test sensation on you. So if you stick your hand out, that's sharp. That's dull. Can you tell the difference?
It's not very sharp, but yeah.
Yeah.
Yeah,
That's sharp,
It seems pretty sharp.
dull.
You can hardly tell the difference. It's not really not sharp enough.
Yeah, it's not very sharp.
Yeah, I don't tell the difference though.
Alright, so if you can stick your feet out for me, close your eyes.
Okay.
Tell me whether you feel sharp or dull.
I'm pretty sure that's sharp.
Okay?
Dull.
Okay, good. Now coming up your legs. Tell me if you feel sharp or dull.
Sharp.
Okay?
That's hard. It's hard to tell. I think that's dull though.
Good. Okay. The other leg here.
Sure.
That's dull.
Okay. It's hard to tell. I think it's not
That's
very
fine.
sharp.
Try.
Yeah, that's sharp.
Okay, good. Alright. And let me see your hand. Keep your eyes closed.
Okay.
And what you feel.
Sharp.
Okay?
Do it again. I can't really. Yeah, I'm pretty sure that's dull.
Yeah, it is.
It's not very sharp, so it's hard to
I
tell.
know. This is a lousy tool, but it's the one they gave me.
Sharp.
Okay.
If you push hard, then I'll be able to tell. Yeah, that's good. That's sharp.
Sharp. Okay, good deal. Okay, so we've assessed sensation, and we assessed sensation in the face, the trigeminal nerve earlier. So now we've done the extremities, assessed sensation. The next thing we'll go ahead and do, since we've done range of motion for the extremities, is we'll go ahead and do the reflexes. So, if I can see your arm, we're going to do your biceps reflex here. Just relax your arm out, I'll hold it up for you.
Okay.
Alright, close your eyes.
Okay.
Think of a nice sunny beach somewhere.
Okay.
Okay.
Is it working?
Good. Positive biceps reflex. That's a +2.
Did you feel that? I didn't even feel it.
Yeah, it's hard to tell. Okay. Make sure now. I'll hold it up here. Okay, there it is. So that's a +1.
I hardly even feel that.
Yeah, it's hard to tell. I feel the tendon tightening up.
Ah,
Is what I feel.
okay.
All right. So now we'll do the brachioradialis here. I'm gonna hold your thumb up,
Okay.
and you can just relax your arm out. I'll hold it up for you.
Can I close my eyes or?
Yeah, close your eyes.
Okay.
Think of a nice sunny beach somewhere.
Okay.
Relax your hand. I'll hold it up for you. Okay, just a little bit of finger movement. So that's a +1. Relax your arm out. Okay. I'll hold it up for you. Okay. A little bit of +1 on that one too. So we have brachioradialis is +1. These are +2. And we'll go ahead and do your triceps. So just relax your arm out here. I'll hold it up for you.
Okay.
Man, it's hard to tell on that one.
Yeah.
Yeah, I think there's a little bit.
I can feel a tiny.
Yeah, a tiny bit.
Barely.
Slight +1
Barely.
on that. All right. Relax your arm out. Think of a nice sunny beach somewhere. Okay. Slight +1 there. Okay. Let's go ahead and move on to your knee jerk here.
Maybe close your eyes.
Close your eyes.
Okay.
Why don't you close your eyes and grip your hands, since you don't have the greatest reflexes in the world. Grip your hands like this. Pull your hands apart while you're doing that.
Wait, pull them apart.
Well, I mean, try to pull them
Oh,
apart.
okay.
Keep them nice and tight.
Okay.
Close your eyes. Okay.
My
+2.
knees work.
Yeah, +2. That one's not as good. Okay, +1 on that one. +2, +1. Okay, let's go ahead and do your Achilles.
My reflexes are good. They know that you're trying to trick me.
That's what it is. You won't be fooled. All right, close your eyes.
Okay.
Okay, +1. Let's try this one. That one is instead not working with me. Relax your foot up.
It's relaxed.
All right. Okay, maybe a +1. Not as good, but okay. So we've done reflexes. Let's go ahead and do one more thing with your feet down here. Now have you done OB yet?
No.
Okay. Well, OB, you're going to do the Babinski sign on babies. You're going to look for the Babinski sign, which is their toes curl up like this and they go like this. We don't want to see that in adults because it means neurological deficit.
Okay.
So close your eyes.
Okay.
Think of a nice sunny beach somewhere.
All right.
All right. Yeah, okay. That is a negative Babinski sign. That's what we want to see right there.
I just did it.
Where you did you do that immediately?
Yeah.
Okay, well, if you were had a neurological deficit, you'd flare your toes.
Oh.
So that is actually a very dramatic negative Babinski sign right there. So good deal. All right. Well, go ahead and stand up for me. And turn around.
Okay.
Now what we're going to do here is we're going to look at your spinal range of motion.
Okay.
So the first thing I'll have you do is I'll have you put your arms straight out in front of you.
Okay.
Now go ahead and touch your toes. I'm gonna hold your hips here and feel. Okay, come back up.
Okay.
Okay, go ahead and do it again. Okay. Come on back up. Okay, now I'm sure you can see that on the camera, it's so pronounced, but he has severe scoliosis here, and the right side of his back actually sticks up significantly when he does that, and then on the lower half it actually sticks up too. So this is raised and this is raised. These two sections of his back are indented. Okay, I'm going to hold your hips right here.
Okay.
If you could Lean to the right for me.
Right.
Yep. As far as you can.
Wait, with just my spine?
Yep, just like that. Okay,
Okay.
come back to midline. Lean to the left. Okay. Come back to midline. So, before we do anything else, we can see that he has a significant inability to go as far to the right as he could to the left. So his range of motion is limited towards the right. So now if you could go all as far back as you can go without falling over here, I'll hold your hips in. Okay, good. All right, good. Come on back. Okay, now twist. Twist to the left. Okay. Okay. Twist to the right. Okay, good. Yeah, your spine is interesting. I'll tell you that. Okay, so we've assessed the range of motion of the
Wait,
back.
is something wrong with it?
Yes, you have severe scoliosis. But so we've assessed the range of motion of the back here. We've noticed that he does have a limitation when bending to the right like this. Most likely because, well, I mean, it's not my place to say. I'm not a doctor. But anyway, so he does have a limitation to the right. Other than that, his range of motion seems to be intact. We've already assessed the next range of motion, and so the next thing I'll have you do is if you could turn around for me. All right. If you could stand. Now I'm gonna get on this side over here. You can stand with your feet together.
All the way together?
All the way together. Hands together. Just stand there for a second. Look straight ahead. Okay, now close your eyes. Okay. So, this is a negative Romberg sign here. The patient's able to stand straight, doesn't sway side to side, so that's good.
I did a little bit. That's a
Barely,
tiny bit.
yeah, barely. All right, now if I can get you to close your eyes for me.
Feet same place? Or,
Oh, you can stand normal there.
okay.
Okay, if I can get you to close your eyes for me. Okay. Tell me what I'm handing you here.
Your hand on your what?
When I put something in your hand, tell me what it is.
That's, yeah, it's comfortable.
Okay, good. So, the patient was able to identify the object, which is known as stereognosis, which is the ability to identify something by touch. So that was good. Let's go ahead and try to think if there's anything else I have to do. I think I've got most of it here. Oh yeah, one last thing. Okay, if I can get you to walk in that direction, just normal.
Okay.
Okay? Now turn around, and before you walk back, I want you to start walking on your toes. Walk on your toes back to me.
Okay.
With one foot right in front of the other. Okay? Go ahead and turn around.
Okay.
Now do it with your heels, one foot in front of the other. Okay? So the patient has no inability to do that. His gait is normal. No disability in terms of being able to walk on his heels or on his toes. So come on back here. And you can go ahead and sit back down. Thank you very much for your time. We had done a complete physical assessment on you.
Cool.
All right. You have a good day. Do you have any questions for me? Okay.
That's scoliosis.
We'll refer you to a doctor about your spine. And that's about it. Okay. Thank you. Hi, my name is John Oxentank. I'm going to be your nurse today. We're going to do a complete physical assessment of you. How are you doing? Good. Good. What I've done is I've assessed that the scene is safe.